Well, hello, everyone, and welcome to this evening's session. Thank you for joining us. I'm Dr. Kevin Spencer, family medicine physician in Austin, Texas. I've been leading a 55-provider independent primary care group in Austin. Tonight, we're going to talk about the independent physician, the partnership model that we're starting to practice in with Agilent Health, and how it's improved the viability of the independent practice and brought the joy back to medicine. I'm joined by Dr. Frank Civitarese and Dr. Catherine Daum. Dr. Daum, would you please introduce yourself and your group as well?
Yes, I'm Dr. Catherine Daum, and I'm with Wilmington Health in Wilmington, North Carolina. And we joined with Agilent about a year and a half ago, I guess. So.
Thank you. Frank?
Hi, I'm Frank Civitarese, and I'd like to welcome you all to the session. As you may have gathered from my background, I'm a practicing family physician, and like many of you, unfortunately, the day didn't go as I planned, and I thought I would take this call from home, but it didn't work that way. So just for reference, I'm in exam room number 5 and just finished my day in the office. I'm President and Chief Medical Officer for Preferred Primary Care Physicians and Preferred Senior Care Advantage. We are a 42 physician independent primary care group in Western Pennsylvania. We have 25 offices and about 320 employees. We've been in practice now as a group independently since 1994, and we are, as I'm sure you'll hear going forward, a fiercely independent group. We love what we do, and we're in the middle of an Agilon partnership, which has been very transformational for us in Pittsburgh and for our patients. So look forward to the conversation.
Thanks, Catherine and Frank. So what we'll do now is I'm going to share my screen, show just a very few slides, I think 7 slides, kind of explaining the partnership, some of the results we're seeing, to give you an idea of what's happening with independent primary care across the country. And then I'll moderate just a few questions for Frank and Catherine to answer. And then at the end, through the Q&A, we will be able to take any questions you may have, and we'll do our very best to answer those. All right, hopefully everyone can see my slides. Again, the title of our session tonight, a partnership, not a pipe dream. You may hear some things that may sound too good to be true. We're living proof they're not. The independence and the viability of it, and what we consider a renewed joy of practicing medicine. So we believe that independent primary care physicians play a really crucial role in the United States, especially as our population ages into Medicare. The statistics that we have available to us suggest there's about 49% of primary care physicians that are still independent in 2020. That's down 5% from 2018 and is down 11% from 2012. So we're seeing this sector decline. All that against the backdrop of an aging population. The Medicare age population will grow by 57% by the year 2034. We also know that while our colleagues all practice in different environments, there's data to suggest that healthcare costs do increase substantially when the physicians are employed by health systems. So as we, as a country, are looking at value-based care, we think the existing capacity in independent practices is a very important part of our future. Unfortunately, I think many of us, we read the same journals and see the same statistics, but physician burnout is real. We know that greater than 50% of primary care physicians have had at least one manifestation of burnout. And again, running an independent practice in the current environment can be challenging. 2/3 of these physicians have at least considered selling their practice. Through the Agilon Total Care Model and the Agilon Partnership, we form joint venture partnerships with Agilent Health. We remain completely independent and the sole owners of our practice. And really what the model is doing is taking primary care that had been in many ways undervalued, maybe even least valued, and we flip that to make them high value by population health management, controlling the spend, having access to the premium dollar. We know that while PCPs only account for 5% of the healthcare spend, our downstream management affects up to 82% of the costs. For every $1 invested in primary care, we're able to yield downstream savings of $13 when done well. So we think this is a very important model, and the Agilon partnership has really enabled that. I'll tell you more about that now. We've proven that value-based care is important, one, for the viability of the independent practice, the compensation to the physicians. We've improved physician compensation very significantly. Our slogan really, as we think about this, is it's better for patients, it's better for you being both the doctor and the patient, today and tomorrow. And so in our partnerships, we take full up and downside risk for the total cost of care of our patients. The physician groups, while remaining independent, do not have the downside financial risk. That is covered by our partner, Untitled Health. We're working closely with the payers. The payers have become our partners, and we've been working with them to improve both quality and efficiency. And so some of the highlights, while many practices, especially with the pandemic, have contracted, the Agilon practices across the country are currently recruiting for greater than 150 primary care providers just this year. We've learned, as many have, that the more times we PCPs touch our patients and have touch points, the better the cost and utilization for the patient is. So we track how many touch points we have with our Medicare age population. We've been able to more than triple the PCP compensation pool. So many of us have been in ACOs, so we understand this surplus or compensation pool. There was an embedded margin in the Medicare lives within our practice that in this full risk model, we've been able to unlock. Some of that compensation pool does go to pay physicians more, our primary care, and even our specialists in our multi-specialty group, but a great deal of it is reinvested in the clinical programs that allows these models to be successful. Our groups are currently all physician-owned and physician-led. They're either primary care groups or they're multi-specialty groups with a primary care centricity and a mission to really care for the whole population. We're currently in 17 different communities in the United States. We're in 8 different states, and we have full risk contracts with 21 different health plans. 5 of those are national health plans. The other 16 are regional health plans. And so we're able to contract with them in a way that we can take the full risk on our patient population. This global risk, as I mentioned, has created significant financial stability as we partner with Agilon. Agilon brings us people, process, technology, and capital to help our practices thrive. In the old model, when we were independent, we were practicing, it was really a payer-led model. We may have a contract with Humana or Aetna or United or a regional payer like Blue Cross, and each of those payers would have a different set of pay-for-performance incentives. They would have a different way that they shared the savings. Whether a patient was part of the pool or not was different payer by payer. And so that was very difficult to manage in an independent environment. It was disparate. It was a very high administrative burden. And it led to a fragmented patient experience. Instead of our patients having the same set of metrics and goals and health goals, we were kind of managing to the payer-led specifics of a contract. In our model, as we take full risk, really we put all of this business onto one platform. So each of the payers, and then also through CMMI and the direct contracting entity, all of our Medicare lives and our practices are in one line of business. There's one brand, we call it Senior Care Advantage. Each market has its own brand that's branded through the independent practices there. We've been able to show a consistent patient and physician experience across that and have a single reporting platform as we really take care of our Medicare population. We really are proud and excited, and I think this is where the joy comes from. In some ways, I don't know that we're working less hard specifically. I think we may be working the same, but we're working smarter. If you look at our experience, one of the things we've learned is the annual wellness visit is a visit we use to address the patient's care plan for the year and document their care plan for each and every one of their medical problems. The national average is about 35% in the Medicare population. We're at 78%. Greater than 90% of our patients, as we poll them, say they're satisfied or extremely satisfied with the care they're getting within our member practices. They also agree at a 95% level that they're getting comprehensive, high quality care. And our net promoter scores that we do for both patients in the model as well as the providers, the patients are at 83, which is really world-class in healthcare, as fragmented and as difficult as healthcare can be for them to maneuver. And then our providers, back to the joy of practicing medicine, in this model, their NPS score is up at 73 and has been climbing. Our outcomes that we've been able to achieve, we're seeing 42% lower ER utilization than Medicare fee-for-service benchmarks across our practice partners. Lower inpatient utilization with 47% less than benchmark, 20% less on hospital readmissions, which is a very important part of the direct contracting quality metrics and something that we pay close attention to. Our patients, and we feel like we've helped our health plans achieve this in some markets. Our patients are 90% of them are in a 4 or 5-star Medicare Advantage plan, compared to 77% of the rest of the population. And then over 90% of our providers, believe that they personally are able to deliver better care to their patients in this model. So those are things that just tell us a little bit about the model. And now I will stop sharing, and then we'll have a few questions for Frank and Catherine before we take your questions. So Frank and Catherine, the future of primary care medicine and how we can best care for our patients as the senior population grows is kind of at a critical juncture. We know that there's not enough primary care to take care of this population. We know that a value-based care model is better for our patients. We all practicing in it feel like it's better for us as providers. Frank and Catherine, can you guys each tell me, and we'll start with you, Catherine, why did you and your group decide to go into a value-based care model and partner with Agilent Health?
Okay. And I'm in a big multi-specialty group, 100 plus providers with virtually every subspecialty. And, we had dabbled in value-based care, but in a shared savings model. It just was a little bit scary, and we were a little bit nervous to jump into a full risk model. So just having the backup of Agilon to cover us if we happen to fail and to guide us along the way was just crucial. We've learned how to do things more effectively and focus on the things that really bring value to a patient in our health system. And I think for the primary care folks, I feel like for years we felt like a hamster on a wheel, just trying to see more and more patients to try and keep up the costs with the costs of our staff and our rooms and that sort of thing. And the only way to do better was to see more patients and to just grind ourselves down a little bit more. With value-based care and the thought of the shared savings, it really was very compelling to think that we could see fewer patients, take better care of them, and come out ahead financially. So that's kind of what made us take the plunge, as we saw other markets that had really succeeded from the partnership with Agilon.
Thanks, Catherine. And Frank, how would you answer that as you chose to go into value-based care with Agilon Health?
So Kevin, as I mentioned earlier, we've been a group now since 1994. I think we've all worked really hard to create an independent, highly successful practice. But what we found over the last 3 to 5 years was that we were continuing to have to invest in the practice with capital resources to try to meet the metrics that health plans required us to meet, but also to improve the care that we're delivering to our patients. So we found ourselves investing out of our pockets independently in quality care nurses and care management and transitions of care. And it was an ever escalating race to spend more money to make sure that we were improving the care that we were delivering. We invested in population health software and IT analytics. And there, unfortunately, as an independent primary care group, there's a finite number of dollars that you can invest before you at least start to see some of that return on investment. And so we found ourselves looking at the future. Despite being very successful, we were being hamstrung in the way we were trying to deliver care to our patients because of capital and lack of capital and ability to invest in our patients and the quality initiatives that we were trying to do. So we felt that it important for the long-term prognosis and viability of our independent practice that we needed a capital partner so that we could invest in the care that we felt we could deliver with the proper resources and the domain expertise that Agilon brings to the table. So it was a decision that we made over probably 2 or 3 years of looking at our practice and how it had evolved and the capital investments that were required to continue to push the envelope in improving the care that we were delivering to our patients.
Thanks, Frank. And then Frank, back to you. You mentioned earlier that you guys in Pittsburgh are fiercely independent. I know you to be so. As you have partnered with Agilon, can you tell us specifically some of the goals that you've been able to reach and achieve through the partnership? And then how does that make you think about your legacy at being able to, as you eventually age into retirement, leave an independent practice behind that can continue to thrive in that environment? Can you speak to those for me?
Yeah, I can. It's been an evolution over the last couple of years, but I think about the way I practice now and the team approach that we've created, and it is 180 degrees different than the way we were practicing in a fee-for-service environment. We've been able over the last 2 years to build out a variety of programs that provide wraparound services for our patients to improve the quality of care we deliver to them. It was interesting because, when you spend years in Medicare in a fee-for-service model, sometimes I think we're blinded to the fact that the vast majority of things that happen to patients happen outside our office. They're not in our exam room. And so we see those patients 3 or 4 times a year, and much of what impacts their health is outside of our visits. And that became very clear to us over the last couple of years. And so we've been able to create chronic care management programs, chronic disease management programs in COPD and CHF. We have several embedded social workers. We have an advanced care planning team that speaks to patients at or approaching end of life. We have transition of care nurses that manage our patients from transition from the hospital to home or hospital to post-acute care. We have an embedded PharmD. We have a nutritionist, and we have a care continuum software program, and I'll be vendor agnostic, that our CIO euphemistically refers to as Where's Waldo. And so this program gets active, dynamic, daily ADT feeds on all of our patients from any hospital in the region, any nursing home in the region, so we know where our patients are. Even though they are not in our office and not under our direct care, we have access to them and we can intervene with them in whether we want to enroll them post-acute care into our care management program or whether we want to approach them with our advanced care planning. All of that is enabled by the partnership that we've created. And as a result, I think over the past 2 years, there's no question that we've transformed the way we deliver care in our offices, and also, more importantly, outside our offices in the community.
Great, thank you. And then Catherine, you mentioned you're in a very successful multi-specialty group in Wilmington, North Carolina. As your group works in this value-based care model, with you being a primary care physician in the midst of a multi-specialty group, what are the ways you're seeing patients get better care and your teams work together in the Agilon model?
Thanks, Kevin, for that question. You know, I feel like it's helped us to be a lot more collaborative, that we have this population of patients that all of us are taking care of. I think in primary care, we've always felt like we're doing all the work. We're documenting when they had their mammograms, their colonoscopy, you know, keeping their glucose under control, blood pressure, and just felt like we were just doing the heavy lifting and the minutia of the day. And this makes it more collaborative. So our cardiologists are giving flu shots, our orthopedists are paying attention to whether someone's had a DEXA when they've had a fracture, or whether they're on a medicine for osteoporosis. So it's made us all take care of all of our patients instead of, here, I'm just going to focus on this and primary care is going to do everything. So it's been a nice collaboration, I feel like, to move to this model. You know, the other thing is just sort of listening to people like Frank, who've been in it longer than we have. And I just think that's amazing to think of the things that other groups have done and that we might benefit from. You know, how did you approach that palliative care? How did you approach those home visits? And we learn from one another how to set up strategies that really take care of our population base. So that's been exciting to us. You know, the other thing is the financial resources to help with recruiting PCPs that Agilon has provided. It's hard to find primary care where we are. It's easy to find specialists. We have a lot of specialist training programs, and they really have helped us to get a lot of primary care folks on board.
That's great, thank you. And you know, my experience in Austin being in the model, really, as you begin to think about taking care of your whole patient, as Frank says, when they're outside of your four walls and you're thinking about their entire life and managing that for a better outcome and kind of a dignified last couple decades of their life, we need teammates. And so a lot of what we've created through the model is care management programs that are far more effective, transition to care. In our market, we actually created a home visit program. So every person transitioning out of a hospital or a SNF, if they're at high risk of readmission, we go see them at their home within 48 hours. We're pressing for transition of cares in the primary care office within 7 days, at least virtually, if not in person. So these things really help us get our arms around our patients without us feeling like we have to do all the work. Because really sometimes they need a nurse or a pharmacist or someone at their house more than they need to be sitting in our office anyway. So it's just a different way of practicing. It's allowed us to think about this differently. And so just sharing that. Catherine, you were hinting at this, but I know you've done a lot of work in this area. One of the really almost unintended values we've seen in the Agilon model is the 17 different geographies around the country coming together to collaborate and iterate and learn from one another and study best practice. And while every community is somewhat different, many of the problems we're tackling are very similar. Can you speak a little bit what you saw at the medical director retreat that we just had in Michigan, and then some of what you're seeing in collaboration and how you've participated? I know you've been helping with the Pinehurst Medical Clinic, even though you live in Wilmington, et cetera. I think that's been professionally satisfying for us as the physician leaders, and a really unique part of the model that we're really all one family across the country.
Right. And I think that was one of the unexpected benefits of this. I think we thought we were just going to go and take great care of patients, but the collaboration with the other providers, we meet, I don't know whether it's monthly or however often, and just, I'm great at copying people. Like, if you have a great idea, I would like to copy that idea. And just to hear the different ways that people have approached things like preventing readmissions, keeping people out of the ER, we have a Today's Care Plus clinic, which is an ER staffed urgent care in one of our buildings. And that kind of came from Columbus having an extensivist clinic where they took care of people that couldn't get seen when they left the hospital. And we're like, that's not what we need. Our primary care folks are able to see them after they leave the hospital. We need someone to keep them from going into the hospital in the first place. So just that collaboration is amazing, just to hear the different focuses that people have, focuses on palliative care, end of life care, just so many different ideas that we might not have even realized needed to be a focus. The cost of medicines, how you keep that down, how to best deal and screen for dementia patients in a day where you just don't have enough time, how to deal with high cost drugs. So it's been exciting to hear from other people and figure out what our needs are and what our patients' needs are really, and see what we can do better. I'm not as eloquent as Frank is, so Frank, you might.
So, Catherine, I think our experience has been the same. I will honestly say that it was a surprise to me, at least, that was one of the biggest advantages of being in this partnership. Each one of the physician groups that is represented in those 17 markets, for the most part, are without peer in their market. In Pennsylvania, we're not a very large group, but we're the largest independent primary care group in Western Pennsylvania. So when we would think of innovative things to do, and we're trying to decide how to implement it and whether it was worthwhile and whether it affected the quality of care, we really had nobody to talk with. We really had nobody to bounce up something off of. And the beauty of this model is that each one of the markets is represented by physician groups that are highly functioning, they're independent, they're industrious, and they're innovative. And so we're able to speak with Wilmington or Buffalo and Austin, and we all know each other by our first name. And so just as an example, we were having difficulty with our diabetic eye exam metric for our STAR scores during COVID. And I called Kevin, and Kevin, I know, had implemented a diabetic screening in his office with a retinal scanner. And he put me in touch with some of his subordinates. And within 3 months, we had it up and running in all 25 of our offices. I mean, I can assure you, if we had to try to do that on our own without any direction or input, we probably would have accomplished it, but it would have taken much longer, and we probably would have had many missteps. So the beauty of interacting with the other medical directors is they can tell you what not to do. They can tell you, no, that wasn't such a good idea. We thought it would work, but it didn't. Or you should do something differently. And I found that to be one of the most rewarding aspects of the relationship, is interacting and partnering with medical directors and physician leaders in other markets that think like you do and live your life like you do in the office. And so there's a camaraderie and an ability to interact with physicians that I never really anticipated to the degree that we've experienced it to date.
Yeah, I would echo those comments. It's been great building these relationships. One of the things we've looked at is many groups are not growing right now, especially independent groups, and that's not been true for the Agilon practices. I think the power and strength of this model has helped us feel as though we want to go take more care of more of our community and grow our footprint and take more primary care patients under our wings to take care of. Catherine, you mentioned this earlier. Can you talk a little bit about specifically how this partnership model is helping Wilmington Health in new physician recruitment and expansion, and a little bit of how they work together with you? And then Frank, after Catherine, if you'd mention a little bit in your market, how you're beginning to see growth differently and certainly have a better preparation for any of your aging physicians to be able to replace them.
Right. Yes, we, have a great need for primary care. I don't think anyone can ever have enough. the problem is it's rather expensive to bring a new provider on, to train them up and cover their salary for the first, year to 18 months as they get up to speed. So, Agilent did make an offer that they would help, supplement that and give us a certain amount of money per physician. And that, I think that makes it a whole lot easier to go out and start recruiting when you have the financial backing, and, the specialists aren't going to complain that we're, spending all this money on primary care folk and that sort of thing. So that was just a huge benefit. The other thing is that I think people that are interviewing see the vision when they see how happy we are and how content, and that we see a very bright future for ourselves. I think that's very compelling, as opposed to going and interviewing at a place where it's like, oh yeah, I see 30 or 40 patients a day and I wish I could see 50. And it's like, no, we want to just really take great care of the patients that are attributed to us. These are our patients and we want to do the best for them. And we're going to funnel all of our resources in giving them the very best care. And that's what I like about this model. Frank alluded to it, but just the concept that I have a population of patients. Honestly, my neediest patients are the ones who don't ever come in, who I never have contact with. And in this model, when you're responsible for giving great care to everybody, you really can focus on those people that have not gotten care at all in the past. They've just been out there on their own. So that's exciting. So I think as people come and see us, they realize how excited we are about medicine and the potential.
I agree. Frank, talk a little bit about growth.
So, Catherine, if you think it's difficult to recruit a physician to Wilmington, North Carolina, you should try Pittsburgh.
I hear it's beautiful, those rivers there.
Yeah, it's well. I'm a native Pittsburgher, so yeah, I think it's beautiful. But I got to tell you, it's not an easy sell sometimes. Right. So yeah, we've had a similar experience from a standpoint that we've added 4 or 5 new physicians. We're a 40 physician group just in the last year and a half. And I think one of the reasons that we've been able to do that is that just like Catherine articulated, we've been able to communicate and tell these prospective physicians that, no, there's a future here. There's an ability to practice the way you want to practice, to earn a good living, and to be able to be satisfied professionally. And we found that to be very enticing to young physicians who are recently minted, and they're faced with a lot of different choices. Most of them are in the employed arena, and that employed arena is very dictated and structured. As an independent primary care group and as an independent physician, we really protect our autonomy, and we're proud of our autonomy, and we revel in it. And so I'm not sure it's for every physician that's coming out, but I think there's a larger percentage of them that realize the opportunity to work for themselves, to be autonomous, and to have an ownership in what they're doing.
Great. So with that, I think we'll start to go to some of your questions in the Q&A. I saw several questions, so I'll kind of speak to the model a little bit that I think will clear up some of the questions. There were questions about, how does the business model work? How does Agilon, as a company survive, thrive in this model? So this is a model where the physician groups remain independent. We're 100% owned and governed. We form a joint venture business with Agilon for just our Medicare lives. So this is a Medicare-focused business. And the only way that Agilon makes money is if we create surplus, and then if we are able to create surplus from the total cost of care model, then we split that surplus, is the way the business model works. Someone had asked, is Agilon an ACO? No, they're not an ACO. They're a company that goes around the country in joint ventures with independent multi-specialty and primary care physicians in this model. They do have the direct contracting entities that were formed. Those are primarily governed by the independent physician groups, but Agilon formed those. And so those are similar and sort of, as you guys probably know, the next iteration of ACOs put forth through the Innovation Center. So we are participating in those. So that's a little bit about the business model. I would encourage you to go to our room here at the conference if we want to talk more specifically about the business, but we'll get to some of the other questions. Frank, you had a question come through that said, would you describe, the members and number of staff members that are managing the panel of patient, reviewing refills, lab results, referral requests, phone calls, and emails from patient, a little bit about your workflow in this model and how you manage the patients with your staff?
Sure. I think that's it's a little bit nuanced because in order for me to give you the numbers, I kind of have to give you an overall perspective of our 25 offices, because many of the functions that I described are handled at a central staff location. So I'm going to give you a real quick. We have 42 doctors, 25 offices, currently about a total of 22,000 Medicare lives between Medicare Advantage and Medicare Fee-for-Service. To service those patients, we have 7 care managers, we have 2 social workers, we have a dietitian, a nutritionist, and all of those people supplement our office staff in each one of the 25 offices that handle refills and lab results. So I think to segment it out, our office staff in each one of our 25 offices handles refills, lab results, referral requests, phone calls. The care management side of the equation, the advanced care planning, the chronic disease management is handled by the 6 care managers. We have a quality care coordinator, a director of care management, RN, and then we also have 4 NPs that handle advanced care planning with several nurses. So I don't know if that answered your question, but that's kind of a thumbnail sketch of how we staff it out. And to be honest with you, we are rapidly expanding the care management model. We anticipate we'll need a total of 10 or 12 nurse managers when it's all said and done, but we need to onboard them systematically and make sure that they're up to speed and do what we're asking them to do. So in the end, I think we'll probably look at 10 or 12 care managers for the population.
Thanks, Frank. Another question was, are we seeing less patients per day, and has that been part of our ability in this model? I'll speak for us in Austin. I think as I look across the country in the Agilon practices, it's varied. It kind of depends on the practice's goals. Some of them actually do want to make more revenue. Some of them want to slow down. And so I think it's different. In our market, we were never a group that was seeing super high volumes. We were averaging about 20 patients a day soon for a full-time, full physician. We've gone down to about 19 so far. But again, part of not seeing a little bit less patients, we also built this care team around us. So the patients we are seeing are a lot less onerous on us. But Frank and Catherine, do you want to speak to how your physicians are seeing numbers of patients?
I think we're a little too new for it to have impacted us yet. I mean, we just barely made it through a year during COVID. So I don't think we've seen the benefit. I do feel like we've been, someone I think asked if we had claims data, and at one of our last group meetings, they discussed a case of this provider who was seeing like 40 patients a day. And looked at the amount of money he was actually losing the practice. In the past, you see 40 a day, you were making bank. But really, because the provider wasn't taking great care of patients and managing the diseases, there was a lot of loss to the group because of that. And they compared that to someone who was seeing very few patients a day, but took great care of the patients. And then in the end, at the end of the year, the value-based payments to that person were huge compared to this person. So getting that perspective where these exact situations have been looked at, I think gives us hope for the future, that if we take, I'm not sure how your group is, Frank, but we can easily see making at least half our salary through the what we've had as shared savings and maybe even make double our salary just by taking good care of patients. So it shifts the whole focus on what you do. And as I heard Frank talk, I thought, oh my gosh, people are going to die to think you're paying for 7 case managers and you want to go above double digits with that. In the past, that would have been prohibitive to have a dietitian, this and that. They lose money for the group. They aren't. But now in this model where you really need your diabetics taken care of, your CHF, your COPDers, care managers are the way to go. I mean, you need their help, and they bring in far more value and better care of patients that you get rewarded for.
So I would say real quick truth be told, I'm a traditionalist. I didn't know there was a name for me, but a recruiter told me one time that I'm a traditionalist, since I still see patients in the hospital, outpatient practice also, but I'm moving to a hospitalist model at the end of the year. And I would say that we've been in the model for 2 years now, and I see less patients. So today I will venture to say I saw 16 or 17 patients. Prior to the agilon model, I would probably see 20 to 22 during flu season, maybe 25 or 26. So I'm seeing less patients. I'm spending more time with patients, and I think they're happy and I'm happy.
That's great. We're down to the last 4 or 5 minutes, so we'll take a couple more. I saw several questions about Agilon's ability to go into rural communities. And so depending on how you define rural, we're in places like Zanesville, Ohio. We're in small towns across Western Michigan. We're in Pinehurst, North Carolina. Wilmington Health, while Wilmington is a medium-sized city, they have expanded out into the rural communities. In Austin, Texas, we've expanded out into rural communities, into places like Kerrville and Fredericksburg. So we do have examples of people being in rural practices. Someone else had asked, how many practices are in Agilon Health? So we kind of have a couple different ways we work with primary care. Many times it's with a tax ID, a single tax ID in a geography, but then we're able to take other practices within that geography and let them have access to the model. And then we've worked in a few places through physician organizations or IPAs, where multitudes of practices are kind of accessing the model through their old kind of aggregator of an IPA or PO. So hopefully that answers some of those questions as we look at that. I think.
And someone asked why we're so happy, and I guess my feeling is,
the last one.
I did not go into medicine to churn through 30 patients a day. I went into medicine to spend time with people and to really form a relationship and take great care of them. And that's why I'm happy, because it gets me back to what I went into medicine for.
I agree. As a leader of other physicians, it's really been rewarding to find a model that works, that I can not only do that for myself when I practice, but for my colleagues, to have an economic model that works, that's consistent, that's all geared around doing the right thing for the neediest patients. You know, one of the things we're seeing, independent physicians would, once they became popular in their community, often would close their practices to Medicare, because economically it couldn't make sense. You could only do so much. You know, we've flipped that, and now we're motivated to take care of the most needy for the right reasons, and we're doing better financially, but more importantly, our mission is better. That's what we all went into primary care for, and that is, you know, to not only do it in one group in one city, but to have the collaboration around the country of people like Catherine and Frank and Mark and Patrick and the people I know that are doing this and really transforming their community is really valuable. And we do it while we're still seeing our community. So we do take commercial patients. They do age into Medicare. We are taking care of the entire continuum, but this focus on our needy ones has really unlocked a business that can let doctors do what Catherine said, spend time with people who need it and accomplish the things that really are their health goals and ways that we can make a difference. So with that, I know we're at time. Thank you everyone for enjoying the evening with us, and It's great questions, and please reach out to any of us if you have more questions. I think you can tell we're pretty motivated to share that we're having a pretty great experience, and we'd love to share that with you. So thanks, everyone.
All right.
Thank you. Appreciate you joining us.